Thank you, Chair, and may I also say how fantastic it is about the news with the vaccine, and thank you for all the work you've both been doing to drive that forward. I have a few questions around the preparations moving forward, and firstly, could I get an outline, just a real clear summary of what the next year looks like in terms of the rollout, please?
Who's that to, Dean?
Patrick Vallance.
Sir Patrick.
Rollout of vaccines.
As in terms of, how we're going to get it to the right people at the right time. Obviously, there's a rollout in terms of vulnerability, but who's going to be doing those vaccines, especially, we're going to have to, there's several million people are going to have vaccines. Is that going to be GPs? Is it going to be hospitals? Who's going to be administering them? I'd just like to get an overview of what that will look like.
So I think Sir Patrick is going to tell me that this is an NHS matter, and therefore the Chief Medical Officer is probably best placed to answer this.
Okay.
Professor Whitty.
So this is an NHS matter, so I'm going to, in a sense, although the NHS obviously has independence, I'm going to speak in broad terms about the kind of approach they're like to take. The first thing to say is that the only current vaccine for which we have emergency authorization for use, which is the Pfizer one, has a very complicated cold chain system at having to maintain it at minus 70 or below with relatively small numbers of, in a sense, changes of hands. And that makes it rather harder operationally than some of the potential subsequent vaccines that might come through. The AZ one we've talked about already, but there are several others that will come through, I think, from a variety of sources later in the year. So the first thing is this is much easier to operate through hubs. But the aim would be to take it out through the system as far as we can. And this is true in all 4 nations of the UK. And, of course, we talk to one another the whole time and try and coordinate our activities as much as we can. When we start off with vaccines, I'm always very keen, as with any other drug, is you want to take things a little bit more carefully to begin with, just so you get to know how these things work. So, for example, Dr. Rain talked about the fact that we were discussing 2 early cases of things. I mean, she and I were discussing this at 11:30 last night, just to make sure. And you start off, in a sense, doing it in centres where actually you've got all the equipment and everything, and then as you're comfortable with them, you feel you understand them, you move them out, and that's part of the kind of standard way you'd think about safety of things. But the aim would be to roll out this vaccine and then any others that get a licence and are effective and safe. And we expect by the middle of the year probably to have a portfolio of 3 or 4 vaccines which we can actually use. And then the first question will be, provided all going fine, no late tumbles in terms of side effects which the regulators find or anything of that sort. The second question will be, the first question is, who do we do it? And the Joint Committee on Vaccination and Immunisation, JCVI, has done a prioritisation list, starting with the most vulnerable and those who look after the most vulnerable as a way of protecting those. So care homes, then people over 80, then people over 70, plus care workers and healthcare workers, and so on, down a list all the way down to people over 50. And we just go down in stages because this disease is one that is very predictably much more dangerous for older people and people with pre-existing health conditions than others. Once we've gone through that first list, which takes us down to roughly 20 million people, then there's going to be some wider choices to make about how do we go from there on. And those will be important ethical and political choices as well as clinical choices. But the first choices are, in a sense, make themselves because they're the people who are the most at risk. And then the final question, and then I'm happy to obviously expand on any of these, is do we need to revaccinate people, and if so, when? And we don't know how long we know that these are very good vaccines to provide short to medium term protection. We don't know how long that lasts. It might last for a very long time. It might last for 9 months. I think it's more likely to be somewhere between those two. And in that case, we may have to have a situation where we have to be in a position to revaccinate particularly people who are the most vulnerable. So I think all of these we'll have to think about as the information comes out on length of effect, efficacy, safety, and so on, and which vaccines best suit which people.
Thank you. Dean, quick follow-up?
So I was going to ask that, actually, which was, are we going to look at an annual vaccination programme, which, by the sounds of it, is potentially the case. But in terms of a good rate of vaccination, if we're having this same select committee in a year's time, what would be a good result for you in terms of a percentage of the population been vaccinated?
Well, in terms of so to answer your first question, whether we need to revaccinate and how often, we don't know. And there are broadly two reasons to revaccinate, one of which is the immune system wanes. So the same vaccine used repeatedly, but you still have to revaccinate. The other is the genetic thing that you're targeting the vaccine against shifts. The infection evolves around the vaccine. This is what happens with flu. Then you have to reformulate the vaccine and then use a slightly different vaccine to deal with the new version. So those are the two situations you might need to do it. In terms of what looks like a good response, absolutely the first priority is to provide protection for the people who are most likely to come to severe ill health, potentially die, certainly could end up in hospital with severe problems. And those are predictable based on the numbers. But some people who are younger, who are not predictable, will still get very severely ill with this infection. So we would want to go down further than that, but start off with the most vulnerable. But that's all about protecting the individual who has the vaccine. There's then a second question to which we do not yet know the answer, which is, do these vaccines, if you vaccinate someone, does that mean that you protect the people they meet? Is this a transmission-preventing vaccine? And we don't yet know that. Now, my expectation is that it will be to some extent, but whether it's a small amount or whether it's a large amount is not yet clear. If it's something which only provides individual protection, some vaccines do only provide individual protection. Tetanus vaccine, for example, only protects the person who's vaccinated, protects no one else at all. So in that case, you're really trying to make sure it's the most vulnerable. If, on the other hand, it's something which protects everyone around you, then it is strongly in the interests of everybody that as many other people are vaccinated, because then it means that people where the vaccine isn't working, where they can't take it, where they've chosen not to take it, they are also protected by the fact that people around them have immunity and therefore are not going to transmit disease to them. But we don't know that yet, and I think it would be a mistake for us yet to say we're going to try and achieve this kind of population immunity, because we're not confident yet whether that is something which is biologically possible. I think it's likely, but it's not definite.
Thank you.
So with that being the case, then,
very briefly,
with regards, the thing that everybody's looking at for the vaccine is around when we're going to come out of lockdown. I think that's the light at the end of the tunnel. At what point, if it's the case that the vaccine only protects the individual and not others from transmission, at what point does SAGE recommend actually lockdowns are no longer needed? Has there been conversations on that point yet?
Well, I'll give a view, and then Patrick will want to give a view. But my view on this is what the vaccine will do for sure, even if it has no onward protection advantage at all, and I think that's unlikely. I think it will probably reduce transmission, but let's assume it doesn't. But what it will do is incrementally, it'll first reduce the mortality rate very substantially, because the mortality is very heavily skewed towards older people. So once you get through that, it'll really substantially reduce it. And then it'll start to reduce the number of people who go into hospital and have severe disease very substantially. And at a certain point, society, through political leaders, through ministers, elected ministers and through Parliament, will say this level of risk is a level of risk that we think it is appropriate to tolerate, just as we accept that in an average year 7,000 people a year die of flu, and in a bad flu year 20,000 people die of flu. That's just, we accept that as that is what happens biologically. And at a certain point you say actually the risk is now low enough that we can largely do away with certainly the most onerous things that we have to deal with. This will happen incrementally. It's not going to be where absolutely everything till one day suddenly you stop. This will be a kind of gradual retreat from that, but it is a de-risking process rather than it's just going to go away. And we will de-risk hopefully to a very low level of risk, but I think it's very unlikely we'll get to zero level of risk. Now, SAGE can help, and this is where I'll turn to Patrick, can help in saying what level of risk there is. It is ultimately a societal and therefore a political question. What level of risk does the population wish to tolerate relative to the damage that is done to other areas, to the society, to the economy and so on? Those are the difficult choices. We're not there yet. For the next 3 months, want to be very clear. For the next 3 months, we will not have sufficient protection. We're going through the most difficult time of year for respiratory infections and the most difficult time of year for the NHS. So the idea we can suddenly stop now because the vaccine's here, that would be really premature. It's like someone giving up a marathon race at mile 16. It would be absolutely the wrong thing to do. But there will come a point where the choice about exactly when to start to ramp things down, how fast and which, needs to be made. And that is fundamentally a science-informed political decision.
Sir Patrick, briefly, anything to add to that?
I agree. It's a science-informed political decision, and what we're looking at is exactly that sort of question as to, depending on the effects of the vaccine on transmission, which we don't know yet, as Chris has said, you would have different models as to what that would mean in terms of the degree of immunity across the population you will end up with that will be relevant to keeping suppression of transmission versus protecting those who are most vulnerable. So priority number one has to be protect those who are most vulnerable. You can see the effects of that. There will still be transmission amongst others at that point, so we need to be aware of that. And then we will know a bit more as we learn about transmission across the different vaccines, what effect they have. But ultimately, then, there are some decisions to be made about how much risk society wishes to take with that.